welcome you all for the scientific webinar on general advisory on precautions in otological procedures. It's my pride and privilege to welcome the eminent speaker, Professor Mohan Commission. I welcome you, sir. And I also welcome Professor Manoj Manikot as a moderator for today's webinar. I'm Professor Shibu George, Professor Anjali, and Professor Amit Kishore, and Professor Shankar Medikari. And also, I welcome Professor K.K. Anda, IAOHNS President, and Dr. Vijay Krishnan, Secretary of IAOHNS. And I also welcome all the delegates wherever you are who is attending this webinar through online. With that, may I request Professor Mohan Commission, please take the stage, please.
Thank you very much, Santosh, and good evening to everyone. Thank you all for joining us for this webinar series of Indian Academy of Otolaryngology Head and Neck Surgery. This is webinar series number 3, and today it's a general advisory on precautions to be taken during otological surgery. Now, as you all know, we have gone through a very difficult time, starting from March when the lockdown started. In fact, ever since WHO declared it as a pandemic, March 11th, from then on, it has been a continuous, up and down and a very rocky road. But nevertheless, the initial hesitation for people to start surgeries has now slowly withered off, because we realized that we can't go on sitting at home endlessly, and we have to at some point of time start surgeries, even elective surgeries. Initially, many centers were only doing emergency surgeries, but even they have now started doing elective surgeries. But there's always this background of fear in the mind of the healthcare professional. Am I taking risks which are going to be costly? And am I subjecting my co-workers and personnel to additional risks? How do we minimize this? So this is a constant worry. And in fact, I constantly get phone calls and messages from colleagues, many of whom are not in big institutions, but have attached to small hospitals or nursing homes, many of them in small cities, small towns, and some of them have their own hospitals and nursing homes. So they want to know how are we going to do this? Are we doing the right thing? So these kind of doubts are there in everyone's mind. So it is to address those issues that we have got some really fine experts today who are all very well-known academicians and very brilliant minds to look at the problems. So we will be having a very erudite discussion towards the end, which will be a panel moderated by Dr. M.P. Manoj, who needs absolute no introduction. I mean, he's a poster boy of ENT, I would say. He's an absolute star. And he's a director, of course, of Manoj Super Speciality ENT Hospital in Kozhikode, Kerala. And one of the very fine otologists, cognitive implant surgeons. He's also a very renowned head and neck surgeon. So, he'll be moderating the panel. But we'll be having a series of talks before that. Now, the talks will be by Dr. Shibu George, who is professor of otolaryngology at Kottayam Medical College, one of the very well-known and old medical colleges in the country. And he's going to be talking about patient selection, choosing the patient who we need to prioritize. It's a very, very important talk. And this will be followed by a very important talk on the patient preparation. What are the strategic steps to be taken? And this will be by Professor Anjali Lepcha, who's a professor of otolaryngology at the very renowned Christian Medical College, Vellore. She is a neurotologist of international repute and a very, very well-known otologist. And she is going to be talking about how the practice in her institution, as well as her own thoughts on how this should be done, how should the patient be prepared. This will be followed by yet another very important talk, which will be on instrumentation. And instrumentation in these types, in COVID times, what has changed? And this is by none other than Dr. Amit Kishore, who's the chief otolaryngologist, head of department of otolaryngology at Apollo Indraprastha in Delhi, and one of the very, very renowned cochlear implant and brainstem implant surgeons. and internationally renowned for this. So he's going to be talking on instrumentation. And this will be finally followed by yet another very, very well-known otologist, a person who is a very, very renowned cochlear implant surgeon, Dr. Shankar Medicary, who's the chief surgeon, Shankar's ENT in Bangalore. And he's going to be talking on post-operative risk control. So this will be short presentations, 10-minute presentations each. No questions then, because all those questions please reserve and post them at when you're going to be having the panel discussion. Because Manoj will be asking questions, and he'll also be taking your questions and directing it to the panel. So it promises to be an extremely useful evening for all of us. So let me wish everyone again very safe and have a wonderful and fruitful discussion in the safe time ahead. Thank you very much. Now let me ask the first presenter, and I think it will be Shibu George. He's ready. Shibu, ready?
Mohan, just a few words from me, and I will
yes,
take over.
Please go ahead, take over.
Thank you. Can you share my screen, please? Is my screen shared? Hello?
So please share your screen, sir.
Okay, fine. Okay, fine. So thank you once again, Mohan. I hope you can see the screen. Is it clear? Vijay?
Very clear. Very
Yes,
clear.
sir. Yes, sir.
Very clear. Okay. So
very clear.
Thanks so much, Mohan, for getting us all together. I think IAOHNS had played a huge role. We are still following the advisory given by IAOHNS in this regard, and for which I have to thank Professor Mohan, Professor Handa, and Vijay for being the leading luminaries here for developing those guidelines. Like Mohan said, we were all very upset when this started. We did not know what to do, but over a period of time, we have learned to adapt. And the people like me are, including everybody here, have been regularly doing surgeries. Especially, we have not been stopping the cochlear implant surgeries that have been happening, simply because any further delay would be causing problems to people. But however, what I do in Kerala and what people are doing elsewhere in the country are very, very different, which is what we will be covering today. Now, like we said, we already had the introduction. So, and then Shibu, like Mohan said, would be talking on choosing the patient. Shibu is a very well-known ENT professor in the country. He is an extremely good academician. He's made a great change in the way things happen in that part of Kerala. He's been a regular faculty in many conferences all over. He's known to be a very scientific and very straight, very protocol-oriented doctor. Kottayam has borne the brunt of most of COVID infections earlier on. Right now, the things have shifted a little bit this side and that side. And they are actually dealing with a lot of COVID patients now. So after the introduction, and thanks to these people, and most of what we'll be discussing today will be based on the standard operating procedures given by IAOHNS, which we'll be discussing with later. So Shibu, are you ready?
Yes, Manoj, ready.
So your presentation is running. You can tell me next when it goes. I'll be muting myself. So your presentation is on now.
Okay, Manoj. Manoj, you will be controlling the presentation, is it?
You can say next or back, I'll be doing it.
Okay, I think there are some animations there. I mean, okay.
Fine. I can play those animations, whichever. Just let me know. I can listen to you.
No, I'll just say next. That's it.
Okay, right.
Okay. Thank you, Manoj, for the introduction. At the outset, I would thank IAOHNS for the kind invite. Thank you very much. And a relevant topic in these trying times, otology surgery during COVID-19. I'm supposed to talk on prioritization of patients. And do we prioritize that? Now, just start the talk by sharing something which I came across when I was going to treat on COVID. Very relevant, I think, to this topic as well. Manoj, next. Yeah, that's it. This is the statement. COVID-19 pandemic is not a time to practice medicine according to protocol, but to practice medicine according to reasoning. I think it is very, very relevant here. Now, there was a time when we thought by reasoning that our middle ear had a COVID virus, and our logic middle ear had COVID virus just because of the continuity of the use station tube. But all changed. Next slide, please. In July, when this has come from Johns Hopkins Hospital, they have isolated COVID virus from the middle ear mastoid of autopsy patient. That it is very relevant that now we think about the standard precautions taken in airway surgeries or airborne droplet procedures in ear surgeries as well. So we shall get on with the topic. Just before going on to otology, what are the standard guidelines COVID or any surgery, not just alone ENT surgery, any surgery? What should be the standard operating protocol? Next slide. Yes, decision on surgery during COVID-19 guidelines, it bias benefit assessment, which is to be tailored to the individual patient. Manoj, next. And in majority, it is advisable to postpone surgery if it is not life-threatening or it carries a less significant morbidity. That early we may be forced to do surgery despite the COVID infection, but in cases we should ensure that the benefit of surgery should outweigh the possible potential risk as well. But while doing so, next please, Manoj. In doing so, we should be wary of this perioperative complications and high mortality surgery in a patient who has been tested COVID positive. We know that a COVID positive patient carries a very high mortality, let alone morbidity rate, almost 13 times as compared to normal surgery. And the incidence of pneumonia, thrombotic complications is very, very high. It is not just the risk, it is the anesthetic risk is also important considering the of the patient. So we have to do, when we are doing a risk benefit assessment, even of in a COVID positive patient, this definitely has to be taken into account. So, and definitely we should have the contemporary of evolving regional condition of the pandemic. We know possibly 2 weeks, 3 weeks earlier, Kerala was in a better position, but now I think all along the country we face three of the pandemic. Hopefully we'll go into a full-blown epidemic where we don't know the stage for which is a full-blown epidemic where we know what it is, and we should hope for the best. Now that is the in general guidelines for design for any surgery during COVID. Next slide, please, Matt. And surgical selection, we have asked about risk assessment, urgency of the risk, and urgency of the management. Again, risk of the surgery which is involved, all are there, and then added to that. Next, please, Manoj. This possibly would be very significant with the evident data which has come out that mid-depth harbors COVID virus. Personal risk to healthcare workers. It's not just just a surgeon doing surgery. With the aerosolization of the bone desk mastoid, it is all involved in the theater as well. Next. Collateral damage to postponement, and Manoj, next. Definitely, as the epidemic progresses, you have to think about this as well, because we possibly the most worst malady which is plaguing developed countries now is actually the shortage of PPE. In course of time, this is going to happen in our part of the world as well, and we have to think about this as well. And we have already discussed about the phase of the pandemic at our locality. So these are the considerations for surgical selection. Next slide, Manoj. Now, this is the standard. This had been the standard assessment. All of us are familiar with this because we take a history initially with history of travel to high-risk locations and history of contact. We go on with the symptomology. of a COVID-19 positive patient, possibly with history of cough, dyspnea, fever. And ultimately, we prove the diagnosis with a formal COVID testing. But no, there are a lot of caveats. So then what are the caveats? Next. Now, number one, possibly most important would be, see, this too, history is almost obsolete now with widespread community spread. So history possibly is out of contention. And again, even in symptomatic, asymptomatic positives are very, very high, possibly to the tune of 10 to 20%. This is all through the disease progression asymptomatic. In some cases, early cases, possibly during the first week, if you consider patients who are in the first week won't show symptoms, possibly it is almost up to 50-60%. That means that majority of patients who come to you who are COVID positive may not be symptomatic, and that is extremely important. Now, it would be expiration date on testing. See, you test 4 days back or days back, and then you set a patient for surgery. After 4 days, the patient can be positive in between. So you have to be wary. This can happen, and the patient has to be kept under quarantine observation. And of course, the standard PCR test carries a lot of false negative results. See, the maximum positivity of a PCR test is all somewhere around 7 to 8 days, which is 80 to 90%. Means still there is 10% false negative results. Early stages, possibly the first day PCR is almost 100%. So it's significantly important when you're doing testing. And that is the reason why majority, there's a lot of literature now about multimodality testing, because to incorporate possibly along with COVID testing, the thorax, should you do that? Because the sensitivity is much, much higher. So all these are cases in risk assessment of patient who has been, whom you are actually planning to take up for otology surgery. Next slide, please. And this is the risk strategy. You stratify high-risk patients and intermediate risk patients. And high-risk patients, next slide. High-risk patients are those patients who test positive for COVID. And that is number one, or who are symptomatic, who are under evaluation. Symptomatic and under evaluation, who is waiting the test results. On some patients, testing may not be practical. And these are the three groups of patients who fall under high risk. Practical in the sense, suppose you have diagnosis to do a surgery, you treat the patient as a COVID patient. Intermediate risk patients, next slide. Intermediate risk patients who have negative on COVID testing or asymptomatic, and still they are taken as intermediate test because of the caveats we had discussed earlier. Next. This is the reason we don't have a category in this point of time in the pandemic, because limitations and variability of the testing we have explained earlier. And next, if at all you have a doubt regarding the accuracy of the testing, you manage the patient as high risk. These are the standard guidelines for risk stratification into high risk intermediate patients. Next slide. And what do you do with high-risk patients? In majority of cases, it's better to postpone the majority of situations as well. Now, this should be at least till patient recovers by testing and resolution. And if just concern non-surgical options. Next, if at all you are supposed to, you are for surgery because of the emergency of the situation. For example, imminently life-threatening conditions. In such conditions, you have to proceed standard COVID-19 protocol in all cases. Next. Now we have discussed this as well. Always be wary of the accentuated surgical and GA risk. So this is high risk. Next is intermediate risk. Next slide. Intermediate risk possibly be the huge chunk of cases which we are going to face, or which we have supposed to do during the pandemic. And this surgical decision has to be based on clinical judgment, indicating, and even the disease severity. Now, it should be a careful balance between the need of the patient and resource availability I have explained earlier. And we have to be wary of the caveats. And based on the risk assessment, we have actually Next. And this is the classification of the surgical indication. Indications have been classified as emergency, urgent, semi-urgent, semi-elective, and elective. Next slide. Now, one good news possibly would be acute life-threatening ear diseases which require immediate surgery is relatively infrequent in otology. And maybe it is possible occasionally, and it's just because majority otology is present much more earlier, and very unlikely very unlikely that we are going to get life-threatening situations. But next, please. That's a caveat. See, patients do pandemic at home, and once they are in there, especially during a lockdown windows, and they ignore that, and then possibly such patients might present as an emergency or semi-emergency later. So that's a caveat. Next slide. So we're just going into surgical prioritization. We have already discussed that they are classified into emergency, urgent, semi-urgent, semi-active, active. Now, this is not a strict guideline. Has to tailor to the individual patient. It depends upon the patient's general condition. It depends upon the duration of the infection. So you cannot just put it in that present that particular categorization of things. But in general, these are the situations where you do an emergency or urgent surgery. Next. Emergency surgery is supposed to be performed within 24 hours. Any life-threatening complications, middle ear disease, possibly are rare. Possibly you could think about separation leading to intracranial complications, lateral thrombophlebitis with severe sepsis and systemic dissemination. Of course, you have a but in the middle, cage of cable into the middle ear, that is again considered to be an emergency. Urgent situations. Next slide. With intracranial complication. Now, you cannot take all intracranial complications to be operated in 70 hours. You have to individualize depending upon the indication and depending upon the patient fact. Traumatic facial nerve palsy, hematoma, facial nerve palsy. Mastocytid responsive to conservative therapy means it has, again, you have to think about the host factor. For example, you have a patient who is a severely diabetic patient who has mastocytitis, it is to the Peter's apex possible. Traumatic injury to the pinna, removal of an implant, and you have an intracranial neoplasm, gastric neuroma, which is producing brainstem compression, hernia, hydrocephalus. These actually might fall into an urgent indication. Next slide, please. Semi-urgent to be performed within less than 1 month, and these are the indications. You can put all Manoj. Now, tumor board-directed otological cancer surgery, foreign body ear, embolization due to meningitis because of the threat of labyrinthitis significans, volume serious leak to the ear, photoria. These fall under semi-urgent indications. Elective, possibly to be performed within less than 3 months, would be lingual cochlear implantation or polycytoma where there is progression as assessed radiology, HRCT. Now, possibly rest indications would under elective where you may be justified in doing it after 3 to 6 months. Even uncomplicated cholecystoma where there is no evidence as assessed by radiology. All reconstructive surgeries of the middle ear, including stepedotomy, and even cochlear implant in a postlingual patient. Now, possibly the vast majority of indications of vast chunk of indications in our surgical practice would be cholecystoma. That is why I just included how do you select patients with cholecystoma for surgery? Next slide. Now, again, the same indication, very good article which has appeared in European Archives of Otology, familiar names there as well, authors. Now, these are the indications of surgical practice cholecystoma. Manoj, you can put all. Now, surgery, you can wait for 3 to 6, after 3 to 6 months in all inactive disease where you have a dry ear, conductive hearing loss, and shows no significant bone. Now, you possibly should do surgery within 3 months, have an active squamous cell disease with evidence of complication, no evidence of complication, but your HRCT shows bone erosion, but not suggestive producing imminent complications. Maybe you have to do surgery within 1 semi-urgent indications when there is significant erosion, the tegment sinus plate or erosion of the semicircular canal and left fistula, or in complications like facial lateral canal, sensory neural hearing loss, especially when the patient has a no hearing here, or even a mastoid abscess or petrositis in where there is an added patient factor as well. And urgent emergency surgery where you have to do within 3 days, 72 hours, possible life-threatening complications like left sinus thrombosis or intracranial abscess. So that is the surgical prioritization, and we know vast majority of our practice was elective surgery. So to do with elective surgery in this pandemic. Next slide, Manoj. Now this is this is the guideline given to their members. Each hospital health system surgeon should review all scheduled elective procedures with a plan to minimize or cancel electively scheduled operations, endoscopies, or other invasive procedures until we have passed the predicted inflection point of the exposure graph. And we are confident that we have resources to do so. This is the idea given by American College of Surgeons. Next, you can put all of them together, Manoj. So elective surgery, otological surgery to be postponed, and this is majority of them are quality of life is related hearing rehabilitation, and in most probability there is no worsening of prognosis. And what should be the time delay? Time delay proposed is indefinite time delay, preferably COVID-19 pandemic results, definite. But you counsel the patient accordingly. You have to give adequate reassurance because for any patient, his condition would be of prime significance. So you have to talk to the patient. Possibly can employ conservative extended management as and when the situation demands. But while doing so, you have to retriage. You have to call him in. You have to case by case, each and patient to call him in, ask about the present situation, review the surgical indication, comorbidities, even the time waiting for has to be reviewed and reassessed. Some cases, probably you may have for added investigation. For example, you have a patient with cholesteatoma, which was seemingly stable. You may have to follow up with HRCT. And if there is an erosion, then you may possibly have to upgrade into your priority group. And more, Manoj. That's what I said. You may have to upgrade to higher priority. I think this possibly would encompass what we intend to do in this particular pandemic in prioritizing patient. And thank you for the patience.
Thank you so much, Shubhu. It's been a great presentation. I think it encompassed everything that we need to see about this particular issue. So I think okay. Now, Shibu's talk was on which kind of patient to choose and what we need to do in COVID times, which is in emergent cases, which is in non-emergent cases. We will get into the presentation later, but there is always an issue about how would hospitals sustain themselves during this time. That we will come to that later when we do the discussion. And for our next speaker, she again needs no introduction, Professor Anjali, very renowned cochlear surgeon, skull-based and lateral skull-based surgeon, is a professor at CMC Medical College. Anjali, I welcome you for your talk on strategic steps to be used in cochlear in otologic surgery in COVID times. Over to Professor Anjali.
Good evening.
Anjali, you are a bit low. Oh yeah, a little bit louder, please.
Okay, I hope I'm audible now.
Yeah, kind of. Okay, good.
Yeah.
I'll be muting myself. You can tell me next.
Okay. So thank you very much to the organizers and Dr. Manoj MP for inviting me to present on this very important aspect of otology surgery. So my talk is going to be on patient preparation for otology surgery and what are the strategic steps that we need to take to prepare a patient for the surgery. Next, Dr. Manoj. Yeah, so as ENT and otologist, I think we always suspected that SARS-CoV-2 virus could probably be isolated from the mastoid and middle ear. And that's because it forms the same, part of the same respiratory tract system. But until recently, we didn't have proof for this. This article from JAMA very recently actually proves to us that SARS-CoV-2 exists in the middle ear and mastoid, and the authors have actually isolated the virus from the mastoid and middle ear in 3 patients who actually passed away due to the COVID-19 infection. So this makes our work in the ear even more challenging. And so we need to rethink all our strategies that we probably followed up till now. So the outline of my talk would be on testing. Then we would go for the consent and counseling, post-test, pre-surgery, what do we need to do, and then the surgery itself. Next. Yeah, so earlier we were actually prioritizing about, whether we need to test a patient or not before otology surgery. But as of now, since the cases have really gone up in Tamil Nadu, and also because we have a high prevalence of asymptomatic carriers in the community, we have decided that all patients should undergo COVID test before any surgery. And the need for a surgery at this time should always be decided by the senior most consultant of the team. An RT-PCR test is what we follow, and we use a very good test, that is the RealStar SARS-CoV-2 testing from Altona Diagnostics, that's from Germany. It's got a very high almost 100% concurrence with true positives and true negatives. So it's a very good test. The turnaround time for this test is could vary from 6 hours to 24 hours. And this depends on the lab, the number of tests it can handle. Next. So as Dr. Shibu has said earlier, we have various categories of patients that we want to operate on. And when we come to emergency surgery, there are those where we can wait for the test report. And usually these are mastoid abscesses and cholesteatoma with complications, maybe a traumatic complete facial palsy, etc., where we can actually wait for the test report to come. So if a patient tests positive in this condition, then the patient is transferred to a designated COVID theater, and we involve the medical unit and the infectious disease unit, and we proceed with the surgery. Now, if the test is negative, then we transfer the patient to a non-COVID theater and proceed for the surgery. Next. Yeah, so there are some emergency surgeries, and this is extremely rare in otology, where we cannot wait for the report to be released. So like Dr. Shibu mentioned, this is probably like a button battery in the ear canal. Or maybe, where the pinna is lacerated and it's part of a polytrauma, case, which has to be rushed into theater immediately. So in these kind of patients, we operate the patient in a COVID theater, and either we take the swab pre-operatively or we take the swab post-operatively. And depending on the result, if the result is positive, we should involve the medical ID and transfer to a COVID ward for further treatment. And if the test is negative, then we transfer to a non-COVID ward. Next. So when we come to essential elective surgeries, now these are surgeries, there's a wide range of conditions which can come under this essential elective surgeries. Generally, these are surgeries that should be done within less than 3 months. Waiting longer for these kind of conditions may cause a negative impact on the outcome. So these kind of surgeries could be like cholestoma surgeries. It could be cochlear implant in somebody who's developed meningitis. It could be a cochlear implant in somebody who's developed bilateral profound sudden hearing loss. Yeah, so or a facial palsy not responding to conservative measures. So in these kind of patients, we always do a COVID test. So if the test is positive, don't jump for surgery. Wait till he becomes COVID negative, and also wait for clearance from the ID. If the test is negative, then we proceed for the surgery. Next. So when it comes to elective surgery, we try to counsel the patient and his relatives for a later surgery as much as possible. But now we have seen that this pandemic may continue for a long time, and sometimes it may not be possible to postpone the surgery for an indefinite amount of time. And this is mainly could be due to patient factors. Also, the hospital needs to generate income in smaller settings or smaller hospitals. So in which case, definitely, again, testing has to be done. And if the test is negative, surgery is carried out. And if the test is positive, wait till it becomes negative and clear it by the medical team. Next. So we come to the second part, which is the consent and the counseling. Now, this is extremely important in these conditions because the implications for having a COVID positive test is extremely huge, especially if the patient is asymptomatic. So it could be a huge impact on not only the patient, but also his close relatives and contacts. So generally, we need to fill up 3 forms. And the form that I have shown on the screen is the ICMR form. This is mandated by the ICMR. Every patient who undergoes a COVID test needs this form to be filled. There's a lot of detail in this form, including the contact details of the patient and his Aadhaar number. If he's a foreigner, then a passport details have to be given, as well as the reason for doing the COVID testing. What kind of swab is it? Is it from the nasopharynx or is it a nasal swab, oral swab? Has to be mentioned in detail. And also the present symptoms of the patient needs to be filled up in this. And most important is the name of the doctor, his or her mobile number and email ID or contact has to be filled in. If any part of this form is incomplete, the lab usually rejects the sample. So it's important for a person to fill up this ICMR form in great detail. The second thing that we need to fill up is a COVID test consent form. Now, this consent form is very specifically designed only for this pandemic era, and it is something to do with how we used to test for our HIV tests earlier. So this COVID test consent form, basically the patient signs that he or she fully understands that there is a pandemic going on and he or she agrees to have the surgery as well as the test done during these circumstances. And if the test is positive, he or she may be quarantined in a hospital setting, and that is right now mandated in Tamil Nadu, and his or her relatives and contacts may also be quarantined. Also, this form, through this form, the patient and their family do not hold the hospital or the health workers liable for any suit, criminal or civil, which may arise from this condition. And then we go to the specific surgery consent form, which details the type of surgery that is being done and what are the complications or problems that may arise for that particular surgery. So these 3 forms should be filled by the surgeon. Next. Yeah. So after the test, if the test is positive, then the surgeon has to contact the patient, has to also contact the hospital infectious control center and the ID team or the medical specialist. Now, again, as I mentioned, in Tamil Nadu, the government mandates that all the positive cases have to be admitted in the hospital and treatment only should be institutionalized. Now, these wards are separate blocks and wards kept for only COVID positive patients. They also have separate lifts, separate corridors, and non-COVID areas are separated from this area. Relatives and close contacts also should be traced, and usually in our hospital, this is done by the COVID command center and also followed up by government health workers. If the patient is negative, as soon as the result is released, he should be immediately admitted to the non-COVID ward, because again, if he goes back to the community, there is a chance that he may get the infection from before the surgery. And if a person is negative and is admitted to the non-COVID ward and pre-anesthesia checkup is done, followed by optimization of his other conditions if necessary, and then surgery. So if there is a delay in the surgery between the first test and the surgery by more than 5 days, then we need to repeat the COVID testing. Next. Now, once the patient reaches the ward orientation is given by the nurses. Introduction to hygienic practices should be elaborated on, and bed distance is maintained between beds in the general ward. Separate hand sanitizer, social distancing, linen, and masks are given for the patient and the attender. Also, the nurses and the doctors who do the rounds and take care of the patient in the wards are in PPE that they wear an N95 mask with visors and aprons. Next. So for the surgery itself, if the patient is a COVID positive or a highly suspect case of COVID, then it should be done in the COVID theater. So in a COVID theater is a separate theater which has a negative pressure. Here, all the staff and the equipment that are present should be ready before calling the patient. The outline of the plan should be made by the senior most person, including the procedure to be followed and the equipment to be that is needed during the surgery. And the patient is transferred from the ward, again in a separate corridor, which is kept away from the non-COVID areas. The patient is transferred with his head cap, N95 mask, and a gown. When he reaches the OT, he is wheeled directly inside the OT. There is no holding bay, and all the surgeons and the surgical team in their PPE do a modified timeout before induction of anesthesia. Again, the extubation and recovery of the patient after surgery is in the OT itself. And from here, he or she is directly transferred to the ward. Next. So the surgical team has to wear a full PPE, that is a bodysuit over the surgical scrubs with a headgear and overshoes. Should wear a hard visor, N95 mask, and plastic apron inside with double gloves. All the extra personnel remain outside the OT, and there are no charts or documents taken inside the OT. Everything is done through electronic medical records. There should be a separate donning and doffing area. Again, this is very systematic and done in a very sequential manner so that there is no cross-contamination. The doffing after the surgery is over should be done inside the OT, and no one should be leaving the OT with used PPE. And this is especially when there are, attenders and class 4 workers who are probably not aware of this risk factor. Then after the surgery, the cleaning should be done for at least 1 hour. And the next case is usually called only when the next team is completely ready. And the OT also, like I mentioned, it has to be modified to have a negative pressure. Next, please. So in a non-COVID theater, if a person tests negative, he is transferred along with the head cap, surgical gown, and mask. Again, the surgical team wears a PPE, that is a surgical gown with headgear and overshoes, visor, N95 mask, and a plastic apron inside. Again, limited personnel are allowed inside the OT. Next. I think that is the last of my slide. Thank you very much.
So thank you, Anjali. I think it is great that you covered that. There will be a little bit of overlap, however, with Amit, but that's okay. We have to do that. So I think we will be dealing with the next part of the presentation. So just a second. Okay. Now, Professor Amit Kishore has been a very old friend of mine. So he was a professor in England as well. He's been here for many years, one of the leading lights in corporal implant surgery in the country. Also one of the very few surgeons like Mohan to be doing auditory brainstem implants as well. He works in extremely high sophisticated setup in Delhi, Apollo hospitals, and the leading the top ENT surgeon and the cochlear implant surgeon there. Amit will be talking about instrumentation in COVID surgery. What has changed? How we should wear the PPE, why it should be worn, and what are the specifications for using separate instruments. Amit, on to you. Your presentation online.
Thank you, Manoj. Good evening, everybody. Am I audible clearly?
Very clear, Amit. Very clear.
Great, wonderful. Okay, so once again, thanks for the opportunity, and let's just go ahead. So my remit is to cover instrumentation. So just next slide, please, Manoj. Thanks. Great. So a little bit of background and science wherever it's relevant. Now, when we are faced with a hazard, like in this case, the COVID-19 pandemic, epidemic, this is a standard protocol for hazard control. There are 5 levels of protocol as mentioned by the WHO. Now, the first 2 are not applicable here in this type of scenario where we can eliminate the hazard, the virus, or we could replace the hazard. These are more for chemicals and industrial and things like that. But next slide, please. But what we can do is that we can go to the 3rd level, which is bringing engineering controls, and we try and isolate ourselves from the hazard. And that means that we create physical barriers between ourselves and the potential hazard. We modify our work environment for airborne infection situations, like in this, where we have negative pressure systems, HEPA filters, and we modify the ventilation systems. Now, this is something that can only be done at an institutional level, a hospital level, to a very small extent at our level. But that's something that is important. Next. What we can certainly do is we bring in the administrative controls for ourselves, for our staff, and change how we work. And that's certainly going to be the new normal, I think, for all of us. And probably this has taught us how we should be changing our standard operating procedures for times to come. And this means that we alter the standard operating procedures, the protocols and practices. We alter patient flow. We bring in more stringent disinfection policies for our facilities and also for instruments. And the 3rd level, which is certainly very, very, next slide, please, Manoj, which is for the individual, is what's the PPE, which is the personal protective equipment to protect ourselves, because that in turn will protect people we come in contact with. Again, from personal safety modifications and instrumentation that we can bring about in our work environment to protect ourselves and our personal sanitization. Now, so next slide, please. So my talk has been taken with these references. I've taken out material from guidelines from the ENT, British Society of Otology, the American Academy. Of course, our own Indian Academy has a very extensive statement, which is very, very useful, and also some stuff from the Ministry of Health and Family Welfare. There are 2 documents there. So these are freely available to everybody. I think they're all very good read. If you can't get them, just let us know and we'll send them out to you. These are all freely available. Next slide, please. Okay, so what's the rationale in otology practice as opposed to respiratory and head and neck and laryngology and things like that? Next slide, please, Manoj. So this has already been mentioned both by Anjali and Shivu on the July paper, but actually if you go back to 2017 and even back to 1999, there has been literature that has shown that coronavirus has been present certainly in nasopharynx and in the middle ear from something like 6, next slide please, Manoj, 6 to 70% of patients. So this is from New England Journal of Medicine in the middle ear. So it's not that the ear is isolated. I think there's no harm in reiterating that even though we think that we are not dealing with the nose and the throat and the airway, nevertheless, the ear does harbor virus in a certain proportion of patients. Next slide, please. So therefore, there is a significant risk that as the virus is present in the middle ear mucosa, as contrast to bone and blood, we have to take care. Next slide, please. Okay, so I'm going to cover personal protective equipment very, very quickly, and then we will go on to a bit of instrumentation. Specific to otology, so there are limited things. So when we are looking at personal protective equipment, what's the rationale? So the rationale is that we divide the degree of care or the equipment level 1, 2, 3 depending on the risk. So this is a risk stratification. So the risk stratification depends on the COVID status of the patient, the known COVID status of the patient, keeping in mind, as has already been mentioned, that there is limitations in the testing. It depends on the instrumentation. Are the instrumentation aerosol generating or non-aerosol generating procedures? Because of course, AGPs will increase the risk to us of transmission of disease. And are we dealing with respiratory mucosa in any form? So any procedure that violates the respiratory mucosa, again, is of higher risk. So if we look at the first line, next slide, Manoj, please. So in any patient where the COVID status is positive, irrespective of the instrumentation, irrespective of what we're doing, we have to use level 2 PPE at least. Okay, and we'll come to that in a second. Next slide, please. So if, however, just run the next 2 or 3, Manoj, please. Yeah. So in the next 2, where the COVID status is negative or unknown, please keep in mind that if it's unknown, we don't know. If it's negative, there's still a 30% chance that the patient may be positive. So in these situations, if we are doing anything which is aerosol generating, then we have to have level 2 PPE, irrespective of whether we are violating the respiratory mucosa. And again, in this category of patients, if we are dealing with respiratory mucosa in any way, irrespective of the testing or the instrumentation, again, it's level 2. So the only situation that we are reasonably safe is if we are dealing with a non-aerosol generating procedure and we are not doing anything with the respiratory mucosa, then in that case, we can come down to a level 1 PPE in a patient where the COVID status is either unknown or negative. So that's the basic principle. Next slide, please. Thank you. So based on that, what do we do in our practice? So we've got our outpatient clinics where we are consulting and examining. We've got outpatient procedures, which could potentially be aerosol generating. And then we've got the OT procedures. So we look at the first one. In the first one, where it's outpatient, where we are just consulting and we're not doing very much else, you could probably make do with a level 1 PPE. You need, now the PPE, please remember, we have to cover 4 or 5 things. We've got to have reasonable cover for the body. It's very important to have cover for the eyes. The conjunctiva is one of the sources of infection, and especially in aerosol. We've got to cover the respiratory system, so you need to have some sort of mask or respirator. We've got to keep our hands clean and sanitized, and of course, where it's relevant, we've got to make sure we have head cover. So in the outpatient, You could make do with a visor, a face shield, or goggles, which have a wraparound facility. You need to cover yourself with any standard. You could cover yourself with a standard scrub. So we encourage that you don't have your home clothes. You change into a separate set of scrubs or clothes for the hospital, and have either a plastic apron or another gown over and above, or an apron over and above your clothes. You could get away with a 3-ply surgical mask if it's consulting, but I think most of us would agree that there's no harm in being cautious, and therefore moving on to FFP2 or N95 mask is sensible in practice when it's healthcare workers. And of course, we need to be gloved. If it's somebody in the reception staff, or somebody maybe out watchmen and things like that, they could get away with the surgical a 3-ply mask. Now, in the outpatient, next slide, please. In the outpatient, we sometimes have to do procedures. Now, of course, here we are not talking about nasal endoscopy or laryngoscopy or things like that. But nevertheless, if we are doing a procedure in the outpatient, then and it's an aerosol generating procedure, then you've got to be a little more careful. So apart from having adequate eye cover, which is a face shield or goggles, you need to ensure that you've got a waterproof gown, the impervious gown, or you can use a coverall. You have to have the N95 or FFP2. What's the difference? Basically, these are different standards. The N95 N standards are the American standard. The FFP, the filtering face piece, are the European standard. So N95 means that you're cutting out 95% of the particles, and FFP2s cut out 94% of the particles. You have to be gloved, and it's advisable to have a head cover. Next slide, please. Yeah. So, and you can choose whether you want, like in the middle, you want to have an impervious gown with a head cover and a face shield and mask, and you can do your procedure that way, or you want to wear a coverall, like on the first slide there, or you can have a head cover like you've seen. So the last slide, so there's a separate head cover with an N95 mask and a face shield, and then there's a plastic apron on top of which you wear your clothes. So that depends on you. And in the operation theaters, Anjali's already shown you, you need to have eye cover. You need to have a waterproof gown. If you have a sterile coverall, that's fine. Otherwise, you have your plastic apron, and then you need to have waterproof gown or impervious gown over and above that. You have to use N95 or FFP2 mask for the minimum. If it's a long procedure, then you could use powered assisted or power air purifying respirators, the PAPRs, and we'll brief mention about that. Advisable to double glove, and also advisable in the OT to have a shoe cover and of course your head cover. So either you wear your coveralls or you cover your head, as is shown in the third picture there. Next slide, please. It's very important, just to finish that, it's very, very important that we have to learn the correct donning and doffing. Again, as mentioned by Anjali, but I think there is no harm in emphasizing. I cannot overemphasize. I think we will agree, and our hospital infection control teams keep telling us that a lot of the time errors happen not because we are not wearing the PPE, but we are not doffing them properly. Donning is not an issue, but when we are doffing them, and that's where the lapses occur, so it's very, very important to go through that. I'm not going to go through that because the previous academy talks have discussed that, but nevertheless, it's very, very important. Please refer to the guidelines on doffing as to the steps that you've got to take. Have somebody to supervise when you're doffing, how you remove the mask, not touching your face. I cannot overemphasize because that's where all the errors occur. Very, very quick thing. These are the CDC brochure leaflets on the different masks. So you've got in the first column the 3-ply surgical mask that we talked about, and the middle column is the N95 respirator, which in the American, as I said, the American guidelines are N95, the European is FFP2, and that's what we would recommend. A lot of us may use elastomeric respirators. You see the second flyer, and the elastomeric respirators can be half face, which is just covering your nose and mouth, in which case you need to have separate eye cover through goggle or face shield, and the full face elastomeric respirators will also cover your eyes. Now, these also, they have filters, so these can replace either the N95 or the N99. So depending on the filter, you can choose to have 95% filtration or 99% filtration. So the advantage or disadvantage is that these are reusable. You can wash them, you can reuse them, and see what works for you. Now, the trouble in otology that we find is that if you're using a full face respirator or you're using a face shield, it's extremely difficult to effectively use the microscope. That's at least what I've found, and speaking to colleagues, that's the same. So in that case, you have to use a half face respirator or an N95 mask, and then you have separate goggles on top of that, because looking through a microscope with a face shield is very, very difficult. PAPRs are powered air purifying respirators. So these are full hoods with a battery operated system where it blows in air so that you have ventilation. They are good for long procedures. They are more expensive. Again, better in institutions where these can be a certain number can be bought and can be circulated amongst the staff. But again, PAPRs are because of the nature of the hood, it's again very difficult to use with the microscope. But that's an option that one has maybe for doing long hours of procedure, maybe head and neck surgery and things like that. So that's a quick overview on the different types of respirators and the PAPR that we have available. Next slide, please. Okay, so I'm not going to go through this because again, this has been covered in detail in the earlier Academy talks, but clinic setup is extremely important, right from triage, teleconsultation, and all the standard operating procedures as currently applicable to outpatient practice with regard to distancing, no attendance, hand sanitization, temperature checks, declaration form, that's all been covered. Regular cleaning, sanitization, minimum furniture, the types of materials to use. Again, I'm not going to go over that because that's not the remit of the talk. During the examination, I'll mention a little bit here. In otology, the main thing that we're doing is, of course, we're examining the ear. So there is a question, do we do otoscopy? And that brings us closer to the patient, of course. So that's a little risk. You could consider doing a video endoscopy. So that gives you a little more distance between yourself and the patient, and microscopy somewhere in the middle. Yes, of course, the patient has to be masked. You're also going to be masked. You have your visor and face shield on. But potentially, if the patient coughs and the patient's mask is not going to be very tight fitting, there could potentially be spread of aerosol, from between the cheek and the mask and come onto your face. So that's a little bit of a risk. So you've got to be careful there. And as I said, video endoscopy is a good way of keeping a little bit of distance from your patient when you're examining the ear canal and the tympanic membrane or middle ear, whatever. Next slide, please. So let's look at OPD procedures. So we've covered the OPD, the otoscopy, the discussion. The couple of OPD procedures in otology are either microsuction or intratympanic injection. Now, in theory, while the suction of the middle ear may not be considered an aerosol generating, but looking at the literature that has already been mentioned about virus being present in the middle ear, I think there is a theoretical risk. So there is no harm in being careful, and which means that you could go ahead with microsuction, but you need to have your basic level 2 PPEs on. So you have your face shield or your visors and your N95 mask, which you do. Also, as I said, keep in mind that during suction, that there may be a cough reflex that may the patient may cough, and that may generate aerosol. So that's about it from the microsuction. You could go ahead with due care. And the same thing applies to intratympanic injection. Again, it is not an aerosol generating procedure, but nevertheless, that basic standard of care that you would follow should suffice for OPD procedures as applies to otology. Syringing, better to be avoided, because with all the water coming out, there is, unless you're sure that the tympanic membrane is intact. Anyway, you would probably not be syringing if there was a perforated eardrum. So in that case, probably you are better off. But again, I think suctioning may be better. There is some thought that you should use a suction without a finger control, thumb control, hole, because again, there may be aerosol coming out of that. So that's just something to keep in mind, please. Next slide. Right. So that brings us to the operation theatre. Anjali is very, very nicely covered everything in the operation theatre. I'm not going to cover that. But again, keep the staff minimum. If you have staff which is familiar with the procedure, you can ensure that there's fast, efficient surgery. You don't want to be in the operating room for longer than necessary. Routine cleaning, donning and doffing, we've talked about that. And for those of us, so you who do a lot of endoscopic ear surgery, you may consider that in place of mastoid drilling, but that's a different discussion altogether. That's just something to keep in mind. Next slide, please. Okay, so surgical procedures. Now, the main thing in otology that we are concerned about is aerosol generation, because surgical procedure, the main surgical procedure that we are dealing with here are power tools, so drills. There's drills, there's irrigation, and there's electrocautery, yes? And we'll bring in lasers for ENT anyway. So I've looked, this is some literature that is very, very recent, and is freely available on the recommendations of aerosol generating procedures in otolaryngology head neck surgery. So that is something that we have to be really careful about. Next slide, please. Okay, so we know that the drills produce aerosol. We know that we've got to take care. Is there any study that's been done on that? Yes, there is, and we'll come to that in the next slide. So very recently, Chen et al. Have demonstrated in a lab experiment the dispersion of particles and aerosol generation during mastoidectomy, and brought in evidence of what a very simple thing that you and I can do to reduce our exposure to that. So please remember, tympanomastoid surgery has to be considered a high risk, even though we're drilling on bone, but we know that middle ear can harbor the virus. So not only for ourselves, but also for our staff in the operating room, it's very, very important. Next slide, please. So what they did was that they had a fresh frozen specimen, and in the lab they drilled it as they would, and using fluorescence and ultraviolet cameras, they looked at the aerosol generation. And these are the pictures of the aerosol that's generated, because they had injected fluorescein into the middle ear mucosa. And so this is the spread of the aerosol with drilling. Okay. Next slide, please. And after creating what they call the auto tent, and that's a very, very simple thing that we all use now. So by bringing out a barrier between the microscope and the patient's head, you're able to contain this aerosol. Next slide, please. And this picture will show you the spread. So the red is hazard, where there is significant amount of particle spread. So as you can see, if you don't have a microscope in your drilling, so the surgeon gets a lot of exposure to the particle spread. If you bring a microscope in the way, the surgeon gets partly protected, but nevertheless, there is still a significant spread of particle. That's the red zone. And the moment you bring in a barrier between the microscope and the patient head, you can see the significantly reduced exposure or spread of particles. So of course it's intuitive, of course it's based common sense, but it was interesting to see that somebody took the effort to actually demonstrate that objectively. Next slide, please. So because of that, I think what we all are doing now, and those who are not ought to do, is a very, very simple technique that lots of us are following. Use a double drape method. You've got a drape on the microscope, of course, and you use another second drape, which is fastened around the objective of the microscope, and you can bring it like a tent over onto the patient's head. In that manner, you are covering the surgical field. Your hands go under the tent or through the tent, depending on what's comfortable. The operating nurse or assistant can pass the instruments again through that. And these are different views to show you how you can isolate the area of aerosol generation through the drill within this tent. It's of course important to ensure that you dispose this properly. Once the procedure is over, then you ensure that you close it properly and don't let everything spread. But I think this is a very, very simple way of doing this. This is again in the Indian Academy. Professor Mohan has spoken about it. It's there in the literature. It's very, very simple. And those of you who are not doing it, we would very, very strongly recommend that you do it. If you use a simple C-arm cover, it doesn't really cost more than another 50 rupees. And it's very, very effective to protect us from the main problem that we have when we're doing otology surgery, and which is the drilling aerosol. Next slide, please. So, so that's about that. Then we're coming to instrumentation per se. Now, all our standard instrumentation still remains the same. What we need to remember is that instruments have to be sterilized. Now, these are both in the outpatient and in the inpatient. Now, most of us are I'm sure, using standard autoclaves or ETO gas sterilization for our instrumentation. That has to remain in place. So if we have maintained the standards, the same will suffice for the COVID virus. The virus that can go away with soap and water will certainly not survive in standard autoclaving or ETO gas. But it's important because we are aware that in many setups, instruments are soaked in glutaraldehyde, in Sidex, or many places they may still be boiled. And particularly in the outpatient setup, I want to mention that we see the patient, we put the instruments into a kidney dish, and they're lying there. Now that's not a good idea, because then that instrument is lying in the kidney dish, and when it dries out, the particles, virus particles, may be spreading. So we would recommend that certainly all instruments should be autoclaved until such time, let's say during the outpatient clinic, if you're not going to be able to autoclave each one at the end of each patient, then they must be soaked in 1% hypochlorite, or you could use silver hydrogen peroxide to soak the instruments, and then your nurse takes them away, puts them together, and then autoclaves them at the end of the day. There is another, I heard someone talk about this other chemical called Persafe, which is peracetic acid, and this is apparently a much safer option to glutaraldehyde. And this is applicable to those instruments that cannot be autoclaved. So either you can use it as an interim, like I just said, when you've got your OP instruments and you need to soak them, you could do that, or your endoscopes and other instruments which cannot be autoclaved, then peracetic acid, 2% peracetic acid, is a much safer alternative to glutaraldehyde. Should be discouraged. It is potentially carcinogenic, and this is a very good, and you can prepare it freshly every day and use it for 12 to 24 hours to soak your instruments for sterilization. Other your tabletops, your other metallic tabletops and otoscopes and things like that should be disinfected with 70% alcohol on a regular basis when you're seeing patients. So basically, to suffice to say that good standard of autoclaving and care of your instruments that you would normally be expected to follow in our normal practice will also suffice for the COVID-19 virus. You don't need to do anything special if you're following these standards. And if you haven't, then you need to certainly bring them into place. So I think given the time and the remit, thank you very much. Next slide. I think that's the end of my presentation. And I've tried to cover instrumentation both from a personal point of view and from an otology practice point of view.
Thank you so much, Amit. It was an excellent presentation. We covered most of the things. People might have had doubts about how to do things. But like Amit said, it's so important that your theater protocols are set for things forever. You can't change things. You can't adapt to new things if something like this happens. We know that these things can happen in the future. More viruses can come in. So the things that you do in your OP, I mean, minus the PP, of course, hopefully this pandemic won't last forever. But the looking at the instruments and your sterilization protocol should undergo a serious change from what you're doing. So thank you so much, Amit. We'll get back to you with more questions later. And now the last person, not the least, is Shankar B. Medikeri. Shankar has also been a very close friend. We all started implants together. A great friend of mine. I've been to his hospital too. But he has got this new wonderful center. Medicare Super Specialty Hospital. He and his very brilliant son, Gaurav Medicare, together, along with some other people, run this in a fantastic way. Very good implant center, great surgeon, endoscopic, head and neck, you name it, Shankar does it. Shankar also was he's the president of the Cochrane Group of India. And Shankar will be talking on post-operative risk control, which is one of the most worrying things that we have about COVID-19. Shankar, your presentation on. I'll be there. You can tell me next. Thank you. Shankar, you're on. Shankar Medicare, are you listening in? I think, are you muted by any chance? Shankar is muted. Will the admin unmute him?
Yeah, sir, we are unmuting, sir.
Yeah.
We are not getting any response from sir.
Oh my.
Oh, yeah, sir. He's okay.
Can you hear me?
Okay. Yeah, we can hear you, Shankar, loud and clear.
Okay. Thank you, Manoj, for the nice introduction.
You have to just tell me next, Shankar, when you change. I'll be muting myself.
Yeah.
Okay.
I would like to thank the IAOHNS for giving an opportunity for sharing our views on this. So let me start. This post-op risk control in COVID pandemic starts from the day you start thinking about a surgery for any particular patient. So most of the things have been covered by this pre-op preparations by the earlier speakers and the instrumentation in the OT by Dr. Amit Kishore very nicely. And I would like to go from there. So before going from there, as you know, this COVID-19 pandemic is the third pandemic of the coronavirus family. So we had earlier two global epidemics like SARS and MERS in 2002 and 2012, which had a very higher mortality, like 36% and 10% respectively. Though the mortality as of now, it looks low in COVID-19, still pandemic is going on, and we are also not very sure about the percentage of mortality being reported from various centers. Next. So the key concerns of any pandemic or an epidemic are now, earlier we have become a global village. Because of this pandemic, also the whole world is being affected. The whole world has become like a global village with 7.6 billion population. So the key concerns of the pandemic are the human life. So every other day you hear one of your relative or a friend or somebody close to you or known to you has been affected by this COVID, and also some of them have passed away. And it has become a big problem for the public security. You can't have a social gatherings, get-togethers. You can't go out easily. And people health has become a great concern during this pandemic. And apart from that, the economic growth of each and every country that has been affected has gone down too much. We don't know how many more years it will take for every country to come up in their economic growth. But whatever is said and done, these epidemics and pandemics, they have their course and they complete their course. Whatever the human population does to identify these viruses, to control or to find drugs to kill these viruses or even the vaccines. And they usually follow these 4 phases, which is called the lag phase, which is the earlier phase of infection, when many of people, because of even the media, people become very much scared about this infection and very much worried. And then there is a stationary phase through which the slow spread happens through the whole community. And ultimately when the 50 to 60% of the community gets infected, then you develop what is known as the herd immunity. And then slowly the virus starts disappearing. Then you will have the declining phase. And after that, there will be a recovery of this infection from the pandemic. So all these phases, how they shape in any particular country remains on the policies which the government, local government takes from time to time, and how the public responds to these policies by their participation in controlling these pandemics. Next.
So the post-surgery risk. So there is one interesting study which has been done by a global multicentric study headed by the University of Birmingham, UK, wherein they have covered 24 countries and 235 hospitals and totally about 1,128 patients. They did this study for 3 months from 1st Jan to 31st March 2020, and they took those COVID infection positive 7 days prior to surgery and 30 days after surgery. The main test done was to confirm for the RT-PCR. Anyway, they also took some risk, which high-risk patients, mainly the risks they controlled was this post-operative death and the pulmonary complication, which they studied in these patients. The high-risk group also included males more than 70 years, malignant disease patients, or the anesthesia grades of 3 to 5 risks, major surgeries and emergency surgeries. So when you come to surgery in pandemic, any type of surgery, surgery, the risks of surgery, you can wait for some particular time, but you cannot keep on waiting for a long time. You have to take all the precautions and go ahead and do the surgery. So it has to be decided on an individual patient and both by the surgeon as well as the patient or the caregiver. Next. Next. So in this global multicentric study, so as you can see in the middle here, so the pulmonary complication rate, which was 3% before the pandemic, has almost gone to 23%. That means there was almost 8-time increase in the pulmonary complications post-operatively. Whereas the mortality, post-op mortality from 10% had gone up to 51%. That is almost 5 times increase. So looking at this, you know that surgery has got a definite risk during COVID pandemic. Next. Next. So the various complications which can happen in these COVID patients when these people undergo surgery post-operatively, there can be worsening of the comorbidities, venous thromboembolism, cardiovascular problems, or kidney, liver injuries, or even neurological complication. And sometimes there can be a cytokine storm, which will be really deadly, especially in elderly people with comorbid conditions. A septic shock or disseminated intravascular coagulation, respiratory failure, all these things can happen. So one has to be very careful. I'm not trying to say that scaring that not to do any surgeries during this COVID times, but one should be knowledgeable and know about these things which can happen, and they try to prevent all these things happening in the post-operative period. Next. Next. So understanding the surgical risk, what is the rationale why we want to avoid or why you want to delay or what should be done in this COVID pandemic? Because they have found that half of these COVID patients who are positive on RT-PCR, they are asymptomatic. And they also found that the viral load determined in asymptomatic patients as well as symptomatic COVID patients is almost the same. So hence, it becomes very important that both asymptomatic patients or pre-symptomatic patients, they have a very high transmission potential of COVID. So all the surgical patients, whomever you are thinking of doing surgery during COVID, should be treated as highly contagious, even though they are whether positive or negative on RT-PCR. They should be treated as contagious because they demand a close contact during surgery, and there will be a prolonged exposure during surgery, and they are submitted to aerosol generating procedures as mentioned earlier during most of our otological surgeries. So all these patients should be considered as COVID, take proper precautions to do surgeries in these patients. Next. Next. Yeah, if you ask, is surgery COVID patients is a risk factor? Definitely yes. Because if you look at how this transmission happens during surgery, one thing is through these infectious aerosols which are generated. Either they can be a large droplets, which will be about 5 to 10 microns, which will have a short range transmission. Whereas the small droplet nuclei, which are less than 5 microns, they will have a long range transmission. So all these aerosol generating procedures, this create this droplet nuclei, which can remain in the atmosphere or within the OT atmosphere for quite some time. So they will be infecting the other persons in the OT. It is not only the surgeon or the assistant nurse, even the other people who are present, they can be infected. So these procedures like even intubation during anesthesia or extubation at the end of the surgery or manual ventilation or even like a mastectomy or when you use a microdebrider for endoscopic sinus surgeries, all these are aerosol generating procedures. And this transmission can also happen through surgical smoke like cautery, what you use, or the laser, the dithermy or the coblator. So preferably one should try to avoid these things during surgery if possible and use as far as possible cold steel instruments for performing your surgeries. And especially cautery, if you are planning, if it is necessary to use, are highly contagious, high risk transmission is possible, and the effect of surgery or general anesthesia on the pulmonary function of these patients is you don't know what is going to happen. Next. Next, Manoj. So what are the precautions one should take to avoid post-operative risks in these patients or whenever you do any surgery during a pandemic, COVID pandemic? So personal protection has been amply, clearly told and demonstrated by Dr. Amit already. I would not like to go into this detail. And he also mentioned about the two microscope covers, one for the microscope and the other for the hood for the patient. And I would prefer to do a self-irrigation system drill will be preferred so that under the hood, only the surgeon will be putting his two hands and using both for suction as well as drilling. And one should avoid cautery as much as possible or else use a bipolar cautery if necessary. And as said earlier, the number of persons in the OT should be minimum, but everybody should have a PPE. As far as anesthesia is concerned, when during anesthesia, there should be 100% oxygen over the N95 mask covering the patient's face. So for 5 minutes, first you must oxygenate with 100% oxygen. Then an expert anesthetist should do the intubation as early as possible. Then connect the tubes onto the closed circuit positive pressure ventilation. Of course, with bacterial and viral filters in the circuit between the machine and your endotracheal tube. And also the expired air has to be left into a 1% hypochlorite solution. There is a tube in your anesthesia machine, so that has to be connected to a solution where jar which contains hypochlorite solution. As mentioned earlier, a negative pressure OT is very ideal for COVID positive patients, but many of us, we may not have this facility. So in such cases, or even smaller nursing homes or setups, so one can have this something which has come newly, a biopurifier 250 mf, which I will show you in the next slide, which has been certified. Next. Yeah, this is the biopurifier which has got here, and it can be covered as you see on the left hand side. The left hand side is the whole inside part, whereas it has been covered with the space, and it can be kept in one corner of the OT, and it will cover area for within 30 minutes. It will do its work, and what work it will do, I will let you know just now. And it will cover an area of about almost 1700 cubic feet. Next. See, the working principle of this purifier is it is a multi-stage filtration to eliminate the suspended particles. So, and it also does the sanitization process. So it has got a physical, chemical, and UV sterilizers inside. So it gets rid of the biological impurities, including viruses, bacteria, and fungus. And the sanitized breathable air is recycled back into the OT so that we don't have any issues in breathing that air. So they have studied this purifier with RNA virus from orthonovirus kingdom with 27 nano diameter was used for the testing this, which is also the same as the kingdom of coronavirus. and it's twice as smaller in size. And they have this process control also is there, where airflow, and humidity control. The output sensors also come into a biopurifier, which comes equipped with real-time, easy to read reference values for ozone concentration, humidity, and temperature of the purified air. This will be a good addition when you are doing this cases or surgeries in COVID pandemic. Next. Yeah, this is the respirator which I always use during my surgery. As I said, half face covered with the goggle, which also covers the side of your eyes. And as shown by Amit, this is the cochlear implant surgery which I've been doing with a double layer of covers, microscope covers, one for the microscope and other for the hood. And I've been doing the surgeries. And you can also see my audiologist also during the intraoperative testing. She is also having full PPE protection. And post-operatively, when that is switched on, and you can see how the audiologist is sitting at quite a distance from the patient who is having this all cables going through a cover, plastic cover. Next. And these patients, all the implantee patients of ours, next, they go for a teletherapy post-operatively after the switch on, so that we maintain the distance from their house. So there is no question of them coming in direct contact with the patient as much as possible. So the staff also are avoided of this risk. So I don't know, the question of comes whether all these health personnel or the frontline workers should be given this hydrochloroquine prophylaxis, which is a controversial question. Some people agree and some people don't, but if we need to give, we have to exclude these complications at 7 weeks. It also helps in preventing or reducing the risk of contacting this infection from the patients. Next. Of course, the use of PPE should be followed as per the guidelines. Just because you are taking a prophylaxis, you can't avoid the PPE. So in management COVID, so we have cases managed either at home or the COVID care center, or moderate cases with pneumonia and SpO2 of 90 to 94% and respiratory normal rate of 24 per minute, they can be still managed in a COVID care center. When the pneumonia becomes severe, when the SpO2 becomes less than 90% and the respiratory higher than 30 per minute, or ARDS or sepsis or multi-organ failure or septic shock, all these things have to be referred and managed in a dedicated COVID hospital. Next. Yeah, mild cases, mainly there is an isolation and symptomatic treatment, checking the temperature, vitals, and oxygen saturation, and only giving like antipyretics or adequate nutrition and hydration would be good enough in these cases. And maybe one can consider giving hydroxychloroquine. Whereas in moderate cases, isolation, along with the isolation, the earlier whatever manuals were doing like temperature, vitals, and other things, one can do a chest X-ray or blood counts or even an ECG, 12-lead ECG has to be done. And other parameters have to be checked once in 48 to 72 hours. The target, one can give a nasal oxygen through the prongs. High flow nasal oxygen can be given to maintain this saturation, or you can give hydroxychloroquine also, like as the doses as I mentioned earlier. And some cases one can consider giving an intravenous methylprednisolone 0.5 to 1 milligram per kg per day for about 3 days, because there is going to be a lot of intravascular coagulation. To prevent that, one can put some of these patients, they'll be put on anticoagulation, like giving a low molecular weight heparin in the prophylactic doses. And one should also take care of their comorbid conditions and keep them under control, like mainly the diabetes, the hypertension, and whatever If they have any immunocompromised status, one has to be much more careful. In case if there is any secondary bacterial infection, empirical antibiotic therapy can be added to these patients as per the local antibiogram guidelines. If any of these patients develop increased breathlessness or any hemodynamic instability or increased requirement for oxygen, they should be referred and managed in a dedicated COVID hospital. Next. In case of severe cases, early supportive therapy, of course, and along with an oxygen therapy of 5 liters per minute to maintain the saturation, oxygen saturation between 92 to 96 and would be good enough. And a conservative fluid management. One should not overload these patients with fluid because they already have a problem in their lungs. There is a problem with oxygen exchange at the alveolar level. So one should not overload. So manage this mainly the hypoxic respiratory failures, either by way of high flow nasal cannula, oxygenation, or an endotracheal intubation, again, which has to be done by a trained and experienced person, and invasive mechanical ventilation can be taken up. And of course, the ECLS has to be done only in expert centers. And management of septic shock and other therapeutic measures like methylprednisolone or low molecular weight heparin also can be considered in these severe cases. I'm just giving the highlights. Next to the management, though, because this is not a total COVID management treatment, what we are giving now. So there are some investigative treatment options which have been done, like giving an antiviral drug like remdesivir, 200 milligram IV on day 1, followed by 100 milligram IV daily for 5 days, which some people has given good results and some it is not. The convalescent plasma also has been from people who have got infected. Usually about 200 ml single dose plasma is given slowly, exceeding more than 2 hours, not less than 2 hours. And there are some cases where remdesivir was not helpful. There has been a possibility of giving even tocilizumab at the dose of 8 milligram per kg to a maximum of 800 milligram at one time, slowly in 100 ml of normal saline over an hour. This dose can be repeated in 12 to 24 hours depending upon the need, if the physician taking care of the patient, if he decides. Apart from that, hydroxychloroquine can be added, whatever benefit it has got. Next. Coming to my last slide, so how to prevent, mainly to prevent all these complications which I mentioned. So it is mainly how you look after the patients in the ICU. One has to reduce the number of days invasive mechanical ventilation to be done as much as possible, reduce the ventilator associated pneumonia, reduce this venous thromboembolism in these patients, or catheter related bloodstream infections and pressure sores, stress ulcers, or even ICU weaknesses. All these are usually taken care, much more careful in these patients of COVID during this pandemic, or even your post-operative patient, even though he was COVID negative and by chance for any reason, if he goes into the ICU post-operatively for whatever reason, so you have to take care of them very well. Next. Thank you very much. I think this is my presentation. I hope I have done justice.
So thank you, Shankar, so much. It's been a very nice presentation. We covered most things. Hi. We have gone through most of the things. We have the panelists been really good in covering whatever that is needed. Shivu did a great talk on the preoperative assessment. Anjali on how we would do the risk stratification. Amit gave a complete cover-up of whatever instruments you need and what kind of precautions you do. And Shankar, I think you covered it up all together, including the post-operative management, which it looks very scary to me, Shankar. You scared the hell out of us. Anyway, thanks. Hello. Okay. Now, there are a few things that we need to understand. One, we'll go to the small discussion now. There are questions, a lot of questions, people asking questions, and I would wish that Janssen people would tell me what question they're asking. Now, we know that there are different stages, and we have already talked about how you would prioritize. There is an acronym that is there in the IAOHNS protocol about emergency surgery, non-emergent. We handled all that. And this is the one that really worries us. Now, I have a few questions for all of you. Shibu, are you actually doing COVID surgery? I mean, any surgery for COVID patients now? Are you doing surgery for COVID patients in Kottayam?
No, Manoj, we are forced to do surgeries. And we do get a lot of emergencies here. And majority of the peripheral setups, they don't take patients. That means that we are not at the liberty of not doing surgery for COVID patients. We have some emergencies we do get, and we have to do. And there are occasional instances where some of us have to go into quarantine just because they came in contact with.
Is it true that when you wear a proper PPE as a health worker, you need not go under quarantine? Is that how it is?
Yes. If you are well donned and off, well PPE, have donned and off a PPE to the prescribed extent, you are not considered as a contact.
Now, one of the things that in Anjali's talk that she was mentioned, that she mentioned about a test that has got some 100% reliability. I have not heard about anything like that, Shibu. What do you think? And I know that you're a person who involved in decision making and what kind of tests that happen in your medical college. Is there something like that is 100% effective?
I am not very sure. I would just request Anjali just to explain on that.
Anjali, I think you should clarify this. You talked about this particular test, the German test, which you said is very reliable. I would be very interested in knowing about that.
Well, so the test itself, they say the company itself says it's got 100% concurrence with absolutely true positives and true negatives. I think the problem comes in the other stages where sometimes when instead of taking a nasopharyngeal swab, the swab may be just from the vestibule, or sometimes there may be trauma or blood in the swab. And the other, factors, the transport medium, the processing in the lab itself, and what is the, quality of the lab and its technicians. I think all those factors also play a role. But per se, the test itself, at least that is what is claimed by the company, this company from Germany, that's what they claim, that they have 100% concurrence with true negatives and true positives.
Has anybody else, Shankar or Amit, heard about this thing particular? Because this is very, very new to me. I've never heard about something like this.
I have not heard
Amit, Shankar?
I haven't heard. I'll have to.
Yeah, I think Anjali, you need to share this, because this is, I think, should go out to people. If there is a test like that and what they're saying is true, I think we are, because right now what we are worried about, what Shibu said about this possible 10% of false negatives, which is actually quite worrying. It may be even be more than 10%, right, Shibu?
Yeah, be more than 10%. The possible 10% is possibly the least number. That is by 7th or 8th day. Earlier on, first day it's almost 100%. First day, and that is really worrying. RT-PCR is
really worrying. Now, there have been some people who have been telling me that a TrueNat test is a good thing. Now, what do you think about this, Shibu? Is it a good thing to do, a TrueNat?
TrueNat, theoretically, it is very sensitive, theoretically. And you do get the result very soon. Within 45 minutes, you get the result.
Yes.
Problem is you can't do it in what? That means that at a time in our machine, in our setup, in our machine, we can do only 4 at a time, 45 minutes, 4 at a time. That means that you have a it is difficult. Theoretically, it is very sensitive. It is much better than RT-PCR. Sensitive. That means that you can know whether the patient is positive or. But the problem practically is it is found practically, especially our experience, TrueNat, lot of TrueNat positive patients later on, beg your pardon, TrueNat negative patients later on turned out to be positive, and there was a big problem.
Now, there was a question about from Dr. Dinesh Kumar, who said that there is an article regarding the presence of COVID in the middle ear. All of you mentioned it. Now, he thinks it is a big thing, but we should have assumed, now that you're taking a swab from the nasopharynx for a COVID testing, how could you not believe that there would be no virus in the middle ear? Am I right, Shibu?
Yes, that's it. It was logical to think that
it is possible.
Correct.
Now, Amit, he is asking, the Dr. Chowdhury Chalsan is asking, is it possible to use a slow speed drill to mitigate the risk of spread? What do you think?
I don't think slowing the speed of the drill actually significantly reduces the aerosol. I mean, of course, there's other issues about heat generation and things like that. So the answer to that is no. I think you still have to carry out the same protection and assume maybe the extent of spread might be less, but it doesn't mean that you don't. So no. And how slow is safe? No, I think it's, if you're drilling, you are generating aerosol.
Yeah, I think I would personally say that if you use it at slow speed, there is more chance of splattering, I thought, because the drill might chatter. That's what I thought.
And it's
now Anjali has got a question which says that, what are the legal implications when the patients are admitted before surgery and tested? In case patient become positive, the patient blamed that they have become positive in the hospital. Dr. V. Prabhu. Anjali.
Yeah, so the here is where the consent form actually plays a very important role, because the patient actually signs on the consent before he gets admitted that he is not going to hold the hospital or the healthcare facility or the workers liable if there is any if he becomes positive, or if he becomes positive and the treatment is prolonged, and the implications to his family and all.
No,
so
Anjali,
other thing is other thing I think is the hospital and the healthcare facilities should have that responsibility of making sure that their own staff are not COVID patients, and if anybody has symptoms or temperature, they should not be allowed to come for work. And even social distancing, etc., has to be maintained, especially in the offices, in the clinics, and the bed spacing, all that. Actually, I think that onus is there on the hospital itself also.
I think Shibu and Amit both described about the standard operating procedure to be followed. Shibu, in the government medical college, do you find it difficult to enforce that standard operating procedure? Do you think that, see, even in my place, we have very strict procedures. Everybody should come and wash outside, came inside, change and stuff like that. But I know from my small place, 90 people, it is easier to enforce. What about you? I mean, is it difficult for you to make sure that every staff who comes in is careful about what he's doing?
It's very, 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 very difficult. See, we do have a comprehensive, and the problem is with the number of, in fact, we have divided into three groups now. To limit contact between us, we have divided into 3 groups. Still, we do have a lot of contacts, especially junior, residents and maybe house surgeons. Possibly it is because of the age don't understand the importance of distancing with themselves. They do fully mingle among themselves. Means one test positive, that possibly there is half of the unit is gone. Big problem now.
Now, because I thought I was doing very good. One day, thought I was controlling everything. One day I just walked into the place where they're having their lunch, and there are 6 of them sitting around the table. I said, this is ridiculous. No, I have spent all my time and effort to give you so much of stuff. That's what people are, it's very difficult. Now, this blaming thing, Anjali, what the doctor asked, I'll come back to you on that. Now, we all take a consent before the patient walks in as an OP. But technically, see, let me look at it like this. Now, you tomorrow do a surgery, mastoid surgery, whatever, and the patient later claims that this is not probably an emergency. Do you find that to be an issue?
Well, I've not personally found that an issue at our hospital. I think that communication has to be there with the patient, give them all the options. And we ourselves, if we try to defer the surgery as much as possible, unless it's something that needs to be done immediately.
Can I say something now at this point of time?
Please.
We had a webinar with, when we interviewed one of the Supreme Court advocates.
I was there. I heard that.
And he is the director of Institute of Legal Medicine. He's a very well-known luminary in legal medicine. And in fact, Supreme Court actually consults him in matters pertaining to medical jurisprudence. And he was very clear. He said two things. He said, first of all, we are now having the pandemic law in OAPS. So under the pandemic law, the hospitals and the doctors are protected, are given immunity from this kind of claims. Where they blame the hospital for getting infected. Second thing is, he said another important statement he made was the onus is on the patient to prove that the infection was from the hospital and not from anywhere else.
So that will be very difficult.
Exactly. So I think we don't have to worry too much about this. I think you are quite safe. You're quite safe during the period. And if both doctor and the patient have agreed that the surgery has to be done, and then the consent is obtained, then after that you are not to be paid.
That's an extremely important point, Man. I'm glad you talked about that. Now, there was an issue recently, yesterday in Kerala papers, there was a child who was sent away from 3 hospitals with a foreign body swallowed coin. And the child was coming from an area where there was a hotspot. And they were told that this coin will pass off in the stool. And apparently the child died after a day. And we don't know why the child died. There's been a big issue. It's all over the press today. Now, this also brings up the point that you cannot actually refuse treatment to somebody who comes in, right? That's very important.
Absolutely.
Can you tell people? Can you tell somebody?
You can't refuse. You cannot refuse treatment when somebody, when you are capable of giving the treatment, and when somebody is having a situation where it could be potentially life-threatening, that would amount to negligence.
That would amount. So I think treating is not a problem. Not treating is a problem. Am I right?
Yes, absolutely.
Now, Amit, there's a question that is directed to you. How do you sterilize the half mask and the full mask? What is the risk of OPD and aerosol in OPD air suctioning? I think that you mentioned. It's not such a. Do you advise this double draping in the OP also in the OP microscope or only in the theater?
No, only in the theater. See, I think the OP microscope, there is the theoretical risk if you're suctioning in the middle ear through a perforated tympanic membrane or in a mastoid cavity or something like that. I think it's very, very negligible. If you have, from my reading, if you've got standard level PPE in place with your N95 mask and visor, that should cover that. You don't need anything beyond that. If you're suctioning the external ear canal, then that's not a risk. There's no mucosa. But so we don't double drape in the OP. It's only in the inpatient when there's a delay. So that's what we would do.
Now, Shibu, you brought about an extremely important point. Shankar also talked about that we may run out of PPEs. Is this, are we doing overkill? See, I like Amit mentioned, everybody in the OP theater use PPE. But one of the things that we do is that everybody walks into the theater, they scrub, put on the PPE, and then between cases, they don't change the PPE, but only scrub and use the surgical gown. Thereby, we use only one PPE per day, and we are using for all the cases that happen that particular day. But do you think that even using PPE in such cases where the risk of transmission is low, do we run the risk of running out of these equipment? You did mention about that in your talk.
I think so, because we need to follow some protocol. Even the US, it's N95 is a hard commodity point. That means that we have to follow some protocol use all the country in uniformity. See, we are not at the liberty of getting all this since I'm working in the government setup. But still, even one day before yesterday, there was a directive from the Ministry of Health and Family Welfare that N95 mask not be used discriminately. Rather, almost triple layer masks serve the same purpose, 95% filtrate virus. So I think we need to ascertain that judgment is paid in this. I cannot be very harsh on my statement, but still, because protection for everyone.
Now, Shankar, you showed me something about an air purifying system. Now, do you also think that those things and your air purifying, filters that you kept in the rooms, the ones that are made by Covey and Philips and all that, or these UVC ovens in which you keep your equipment, are those really effective or are they overkills? Shankar.
Manoj, what I showed, that is a recent thing which has come. I don't have it at the moment in my OT.
Oh, I thought you have it.
No, I don't have it. It has been produced by some local company in Bangalore. I have seen it in another hospital where they have been using it in a Sagar hospital. So my anesthetist comes also has told me, gave me that. So I thought for a centers like ours, where there are small nursing homes and things like that, it may be useful. That is why I just showed that, but I don't have at the moment. But I
So
don't.
when the community spread happens in a quick thing, do you think these things like keeping an air filter, the people who are making air filters are making a killing. They're making a lot of these air filters.
It should be workable. It should be good.
Do everybody here, Anjali or Shibu or Amit, agree that air purifying filters inside the room would make a difference, Mohan?
I'm not very sure.
Not very sure.
Yeah, not very sure because I don't have personal experience.
What about these UVC ovens? They are also being sold like hotcakes now.
Yeah.
I wish I had a company that made all this stuff.
The problem with air purifying filters in surgery is actually in fact, you should at least wear a mask over that because you are allowing exhale air through the filter to go into.
Okay.
I do even ethical without a mask.
No, Shibu, what I showed, this purifier, what I showed was all other things you have to do as per the protocol. You are not doing anything. This is an additional thing.
In addition.
Okay. Point.
Yeah.
Okay.
I think
Now, how
Sir
do you
mentioned
do
that
this?
if you don't have a negative pressure, you use this.
Smaller setups.
Okay. How do you do this negative pressure, by the way? Can you convert your theater into negative pressure without spending a fortune?
I think in CMC they have done that for few theaters, which we are using as COVID positive theater. I'm not very sure the engineering part of it. So.
Have they done it in Apollo Hospital, Amit, to make it negative pressure?
Only in certain rooms where they do the COVID testing, positive patients and the COVID case. That's it. I don't know what it entails. I know, of course, it's not easy to do and it must be costing.
It is. I think what I heard was for a theater, it costs between 3 to 4 lakh rupees.
Not in the routine.
Shankar, you mentioned about avoiding cautery. Is it really necessary to avoid cautery?
Monopolar cautery, I think so. But bipolar cautery, if required, maybe can use. Even I think Mohan also was of the same opinion.
Yeah, I think it's the same. It's the same principle like in viral papillomatosis, the laser plume and the cautery plume can carry virus particles. So it's using that analogy. Extrapolating from that analogy that if you've got smoke plume, you may have virus particles. Therefore, you might be better avoiding that. Bipolar is better.
Bipolar.
That's where it came.
We have not really talked about anesthesia in COVID practice. If I would ask particularly Amit, these are things from Mohan's theatre. This is what we also do. Use the same C-arm cover when they're intubating. Do you think in GA or a LA, which would you prefer in these times?
I think GA would give you better control of the patient's airway.
Exactly.
And therefore, less likely with the patient coughing, spluttering and all that. But if you've got the tube in and it's cuffed and you've got the cuff inflated and you have a good evacuation system for your gases, then a GA is a better option.
These green things that you see there, the HME filters are actually quite efficient viral filters.
Yes.
And if you can use it both on the patient side and on the machine side, I think it's really, really well protected because a local patient can cough and sneeze and even vomit, which could be a big issue. Am I right?
That's correct.
Already directive. Already there's a Manoj from the health. Already there's a direct Ministry of Health and Family Welfare. You can hear me, Manoj?
Have I gone off or have everybody else gone off?
We can hear you, Shibu.
Yeah.
Hello?
Manoj.
Yeah. Tell me, Shibu. There's some problem with the internet connection.
Already there is a directive from the Ministry of Welfare that none of the aerosol procedures should be done. That is a directive already.
Yes.
It has come out.
Wonderful. Yeah. Okay.
Can I make one more? Manoj, please. Make one one more point on diagnostic part. In fact, I just missed that.
Hmm.
See, we have a lot of incidents of false negatives. You can bring down the false negatives, you can incorporate into the diagnostic protocol. The problem is including radiology. Just radiology is again, whether you want to subject the patient to irradiation. So
Okay.
two options here. One is anyway you take an HRCT of the temporal bone in a patient in a patient. In such cases, if you can add limited cuts, limited radiation thorax, very high diagnostic value, possibly something up to 99 diagnostic value. Now, still, if you are kept about radiation, you can even add an ultrasound, chest ultrasound, very line sensitive. Very only thing is it is lacking. Still, you have a sensitive information which is 90% sensitive in diagnosis of COVID. I think there is a study which is running in from the where they are actually collaborating with IT and they are just and sound just ultrasound, and they're just trying to make a simpler machine, something like our no, something like cochlear echoes, which at a semi-skill level as well.
Oh, that's really great. So I think if you have something like that, we can actually really cut down the number of false negatives because we have one more parameter put in place, right?
That's it.
And we were worried about this CT chest because of the number of radiation exposure that a patient would have to face. That's the only issue that we're talking about. Now, regarding what Amit mentioned about the donning and the doffing, this is the donning and this is the doffing, which is so very important. I hope all of you have these posters put up in your hospital about how to don and doff. Do you have training protocols running in place? Shibu and Anjali run big hospitals.
It even started in April. The training protocols started in April.
Okay. The problem is that unless you constantly monitor, this can easily go down. That's the problem with all training protocols. Like you said, people tend to get complacent after some time.
No. I make it a point at least every 2 weeks to go and visit.
Okay.
Yeah. So we have
This is a message for everybody who's listening in. I do not know how many of them are because considering the number of webinars that happen on Sunday. But I think it's an important point to constantly review these processes of donning and doffing.
Yeah.
Now, Shankar, you mentioned about intraoperative testing for CI. Now that all of you here are doing CI, we can actually remotely test. In fact, my audiologist doesn't even come to the theater. You can connect by internet and do a testing without the audiologist entering the theater itself. I hope that people are doing it. I think Mohan's place, they're doing it. No?
Yeah, we are not doing it.
Our audiologists don't come in either.
They've not been coming in. We are our main load now is CI because we are cutting down other procedures and all the CI cases that we do, it is being remotely mapped without anybody coming into the theater. There's a dedicated laptop. You can connect it to one of those mobile phones with a Wi-Fi, and you can do all the testing possibly. So what is happening now is that the OT staff knows how to know NRT. So I don't know if that will be a threat to the audiologists, but they know what is to be done. They're not going to be very happy about that. Now these drapes, is everybody using them? They are quite cumbersome, Amit. I hope you agree, but I think it should be in the best interest of safety. Your study that you showed was fantastic. Shankar, are you using them always in your surgery only?
I am using regularly for all of
Anjali.
If it involves a drilling procedure, but if it's not a drilling procedure, then again no.
Okay.
For a stapedectomy, I'm not using Manoj, but for
stapedectomy you can't. Yeah. But when you're drilling, it's better to use.
Cochlear implant surgery, I use.
Mohan, are you using the same drape, or have you modified it some way to make it look bigger?
We modified it, Manoj. In fact, Vijay was responsible for that. So we actually, what we have done is now, whether it's the right ear or the left ear, we have two mirror image modifications, and there's a kind of map for the a nurse to assist. and it's much better design now. So it's one of our.
Can you please share those designs and who was manufacturing, because I would like to have them. I find them
I
good
think
to use but extremely cumbersome.
I can send it to Vijay and ask him to send it to everybody. But basically, it's the same company which makes the microscope cover for us. So these guys who have made the modification. It's a very simple, very minimal modification, but just a little more space, roomier, because the microscope cover is found very narrow and it's very constraining.
Yeah, that is a problem for me. It is actually quite narrow.
And also it comes down a little lower into the chest, so we can tuck it around the patient almost up to that level. So little longer.
With a kind of waste being generated, how concerned is everyone about this? Because we're doing, but I guess we have to learn to live with it. But there is a huge amount of waste being generated because of these protective equipment.
Yeah, I agree. There is that is a concern, and that's a global concern on the masks and the disposables. And that has been, discussed at a global level. But I don't think we have a choice right now.
We don't have a choice right now. So I think we have come to the last part of the thing. I think maybe 2 hours now, almost 1 hour, 58 minutes. Vijay, I think we are good, right? For the time, we have covered most things. Anything else that somebody wants to contribute to this? It's been a great discussion. I think I've learned more in this webinar than many of the webinars that I attended in the last 3-4 months.
Yes. That's a complete discussion on.
Complete discussion?
Complete discussion on otology. Full aspect is covered.
Complete discussion on otology. We don't have. In fact, I find it really shocking that people are doing rhinoplasty and all in these times, because it is a terrible thing to do. I hope you agree with this. We should not be doing cosmetic procedures during this time. I would really agree with you, because we should not be taking this lightly. It is bad times indeed. The only things that we really are doing upfront is cochlear implant surgery, but the rest of them, I think we are trying to postpone and keep away as much as possible. Certainly no tonsils, because they are not real emergencies anyway, and airway surgeries. So it's been great. If I recapitulate, Shibu's talk was one of the best I heard in recent times. Fantastic exposition on whatever should we do. Anjali did everything about what are the protocols to be followed. Amit showed us exactly what are the minimum equipment level that needs to be used. He clearly decided what was to be done in OP when we do an OP procedure, when you do a surgical procedure. And Shankar gave a big exposition about what treatments to be initiated. I wish we don't even see any of those drugs. It is pretty scary just looking at their name, Shankar. So it's been great interacting with you. And I would thank Mohan and Professor Anda and Vijay and the Janssen people for, I can't see any of you guys. Okay, for interacting with us. It's been a great 2 hours. I never knew that I could spend 2 hours so effectively. Thank you so much, Anjali. Thank you, Shibu.
Thank you so much, sir.
Thank you so much, all the speakers.
Dr. Handa.
Thank you very much.
Thank you very much.
Shankar, you want to say something?
No, Dr. Handa was supposed to conclude, no? Is he there? Or
Yeah.
Yeah,
I'm there. Thank you. It was very comprehensive to us of coverage of otology, likely practice, and what should be our current practice. But let us understand, COVID situation is changing daily. What we say today may not hold good in a week or so. So we must be ready to change. Today, in some bigger cities, the peak is plateauing. Maybe now the descent will start. There are newer areas being added. So it is geographical area specific also. Again, otology, we may think that the problems may occur only in laryngology, airway, head and neck, but no. As all the speakers they brought out, there are very important aspects to be covered in otology practice also. And it was very good moderation by Dr. Manoj, Dr. Shibu, Dr. Amit, Dr. Shankar, and Dr. Anjali. Thanks for your contributions. This is one of the series of the similar webinars by IAOHNS. We are going to have a series on different aspects of practice of ENT, area specific. So wait for the next one. And thanks for the sponsors. Thank you very much.
I would request Mr. Prabhu to say a few words.
Yes, sir. Good evening once again to all the panelists and the audience across India. They are attending. We are very pleasure to collaborate with the IAOHNS series of webinars. So for that, I would like to thank Professor Mohan Kameshwar, the chairman for the academy, and President Dr. Handa, and Dr. Vijay Krishnan, secretary, so we've been always coordinating with us and making things happening. And for today, the moderator, Dr. Manoj, actually really moderated well the session and the Q&A session also. And the speakers, the panelists, especially Dr. Anjali, Dr. Shibu, Dr. Amit, and Dr. Shankar. So all of them have given and they share their knowledge on this current happening in ENT, and that will be useful for all the audience who are attending today. Hope that will be great sharings for them also, take home messages for them also. And thank my colleagues who are all also joining across India, and they are also contributing to this to their doctor, and they are inviting their customers also for this meeting. And once again, I thank IAOHNS for this collaborative event. Thank you, and thank you all. Good night.
Thank you
Very much.
Thank you very
Thank
much.
you.
Thank you.